Okay, so Dr. Sandberg-Lewis, thank you for sparing some time and welcome on to the podcast.
Glad to be here.
So it would be great to kind of dive into the topic of SIBO with you today, and perhaps also explore some of the less well-known symptoms or conditions that potentially could be associated with it as well. So I'm not sure if you have a clear idea of where you would like to start. We have had Tracy Randall on the podcast before, and we kind of covered, I guess, an overview of SIBO. And I've spoken to Dr. Jacoby a little bit about some of the most common underlying imbalances that can contribute to SIBO. But perhaps a good start would be to share with our listeners a little bit about you and your background for people that aren't familiar with you, and then maybe your thoughts and your perspective on SIBO and how it fits into the bigger puzzle, shall we say.
Okay, so about me, I've been a professor at the National University of Natural Medicine for the last 22 years or so. Also taught back in the 1980s. I've taught hundreds and hundreds of naturopathic physicians. I taught pathology for 17 years, which was a real education. And now I focus all of my teaching on the GI tract and digestive health and disease. And I supervise student doctors as well on a year-long rotation where they can see complex GI patients along with my supervision. I have a private practice 3 days a week, and I write and lecture and all the other things I do. Graduated National College of Naturopathic Medicine back in 1978, before a lot of your listeners were born, I hope. So that's a little background about me. I'm a musician, and I'm very physically active. So that's a little bit about me.
Brilliant.
About 10, 11 years ago, I was teaching a 2-weekend course on functional gastroenterology, and Alison Seebecker was one of the students, doctors attending that course. And when she heard me talk about SIBO, some light went on in her head, and she just got completely focused on it. And so for many months, we would meet every 2 or 3 weeks and just for 3 hours talk about all the research we had been reading, because there's so much. Since 2000, there's just an explosion of research on SIBO and the microbiome in general. So we just started lecturing together, writing articles together, eventually seeing patients in the same place, and starting the SIBO Center at National University. And there we did testing, educated the public and doctors, published articles and books, as well as seeing patients, doing patient care, and trying to come up with innovative new treatments. So that's a little bit about how I got into all this.
Fantastic. Yeah, and I didn't know the connection with Dr. Seebecker actually, so that's fascinating.
Yeah, she had been a former student of mine when she was in her graduate training, and took that postgraduate course with me, and just got turned on to that as her full focus for the last 10 or 11 years. Anyway, you wanted to talk about conditions not as well known that are associated.
Yeah.
Well, I'm not sure what your listeners, how much you've looked into this, but probably the biggest one, and shows how central this is to systemic health, is hepatic encephalopathy. You think everybody's aware of that?
Some of our practitioners will, but we do get almost an equal amount of the public who won't. So certainly expand. That would be great.
Yeah, so for instance, the most common prescription medicine used for hydrogen SIBO, rifaximin or Xifaxan in the US, if you put that in, put liver and rifaximin, I think Google search, you will just go right to the site for hepatic encephalopathy, because the ammonia that's produced in the gut from ingested protein, when it's acted upon by the small intestine flora, is in high amounts is extremely toxic to the central nervous system and the peripheral nervous system, and leads to profound and dangerous changes called hepatic encephalopathy, sort of the toxicity of ammonia to the central nervous system. And when I was doing my graduate work in naturopathic medicine, I spent a week at Mercy Hospital in San Diego, and we were in the emergency room one day, and this elderly woman came in a coma to the emergency room, and I thought, wow, what's going on here? And the doctor I was with did a brief exam and said, we know this woman. She comes in every few months in hepatic coma.
Wow.
Due to hepatic encephalopathy. She's a very chronic alcoholic. And so, and therefore she had cirrhosis that led to this problem. And I said, how do you treat it? He says, we give her an antibiotic enema. That was the treatment back then. If you could kill off a lot of the bacteria, even in the large bowel, you would greatly reduce the amount of ammonia being produced. And nowadays they use rifaximin to reduce the overgrowth of bacteria in the small bowel. And that's what often dramatically helps with hepatic encephalopathy. Another perhaps more down-to-earth common condition is NASH, or non-alcoholic steatohepatitis. Very, very much through research been shown to be related to numbers of bacteria in the small bowel and the lipopolysaccharides and other bacterial metabolites that go right through the portal vein from the small bowel to the liver and lead to fatty deposition. So even erosive esophagitis, reflux esophagitis in the lower esophagus, is highly related to SIBO. So there you have just some ancillary digestive disorders that beyond the small intestine, because really the small intestine is, remember, I teach a course called GI Lab, and I teach another course, co-teach a course called Advanced Gastroenterology, and we wanted to call that course The Small Intestine is Not Small, but they thought it sounded more professional, Advanced Gastroenterology. And we spend about 16 hours of lecture just on the small intestine because it's so important, and it is the largest part of the digestive tract by far. 18 to 20 feet instead of maybe 3.5 feet of large intestine.
Yeah. Fascinating.
I could go on about other conditions, but do you want to kind of tell me where you want to go from here?
Yeah, sure. No, I think that's really helpful and really interesting. And as you say, shows the connection between the small intestine and systemic health. It's kind of that central hub of digestion and absorption, and intestinal permeability is, I believe, more prominent within the small intestine as well. I'm also just thinking of some of the topics that I know that you've sort of researched and written about, and I'm quite curious to, if you're happy to explore and pick your brain around things like pancreatic function and the ileocecal valve, and and how these can come into maybe chronic cases of SIBO.
Yes. Pancreatic insufficiency, I test almost all of my patients who have SIBO for it because it is a common underlying cause for SIBO.
Okay.
And I like to say the pancreatic secretions, the gastric secretions, and the biliary secretions all entering the duodenum are the upper, sort of the upper gate or upper protector of the small intestine. So here they are all entering at the very beginning of the small intestine, and they create a very aversive environment for bacteria. You know, the bile starts to emulsify their outer cell walls. And, you know, there's a lipid component there, as you know, from the lipopolysaccharides that are a big part of gram-negative bacteria especially. And the gastric acid is an aversive environment as it enters the duodenum, as is pancreatic enzymes, which are proteolytic and break down fats and carbohydrates as well. So this soup of very toxic, that creates this very toxic environment for them, keeps their numbers low. And that's what we want, you know, less than 1,000 per gram of fluid, as opposed to millions in the large intestine, which is normal for that location. But this, you might call it, it's not really toxic, but to them it's kind of an aversive environment. It is created here in the upper small intestine and should really keep the numbers very, very low. When you take any of those three out, we know that proton pump inhibitors, has been a lot written about the hypochlorhydria or achlorhydria, increasing the risk of bacterial overgrowth. And we know that even in the stomach, bacterial overgrowth occurs when the pH of the stomach is above 3.8, which is still rather acidic.
Yeah. But
it should be less than 2 usually. And so acid's very important. Pancreatic enzymes are very important. If you have pancreatic insufficiency, and we measure that with the fecal elastase or fecal chymotrypsin levels, and if elastase, for instance, is less than 200, it's diagnosable mild to moderate pancreatic insufficiency. I find even patients with elastase between 200 and 300 can still have problems with bacterial overgrowth. You know, it's all a matter of some group getting together and finding a number as a cutoff between normal and abnormal, but it doesn't mean it's ideal. And if you put some combination together of someone who's taking a proton pump inhibitor or and at the same time has mild to moderate pancreatic insufficiency or something close to that, and maybe their bile flow is slowed down, it's more, they've got some bile sludge and their bile is flowing poorly and slowly, you got a perfect recipe for someone who's going to need to be treated for SIBO over and over and over, because they're going to keep coming back if you don't deal with those basic issues.
Yeah, that's really interesting, and I think a great summary of some of those upper GI endogenous defensive mechanisms. And I was going to ask you around sort of elastase and the markers, because I've often sort of viewed almost 350 as a bit of as questionable. If someone's sort of 250, 300, 350, then I'm certainly wanting to know a little bit more about their symptoms and things like this before I rule out there being a little bit of a pancreatic issue.
Yeah, I've come up in my book, Functional Gastroenterology, I have a chapter on pancreatic function. In the second edition, you know, I've been thinking about this for a long time, and I'm glad that you're already doing that. You know, going outside the box of greater than 200 can still be a problem, because we see many, I'm sure you see many of your patients when you test them, the elastase level is greater than 500. They don't measure, most labs won't measure more than 500. They'll just say greater than 500.
Yeah.
And a lot are greater than 400. So I have started to think, and I put this in the chapter, this area between 200 and 400, that's not ideal for most people. You know, greater than 500, that's really a good level. So if it's between 200 and 400, I call that pancreatic function of undetermined significance. You know, I just came up with
Nice.
a term for, hey, you know, this is not necessarily right. It's not ideal. And what we need is ideal to keep all these things, you know, to prevent malabsorption. Especially, remember, another piece about pancreatic insufficiency is if you have a lot of disaccharides and larger oligosaccharides floating around because you didn't have enough pancreatic enzymes to break them down to disaccharides, you're going to have a lot of food for those bacteria up there. It's really going to feed them. So it's another mechanism by which they overgrow. So yeah, pancreatic function of undetermined significance between 200 and 400. I really keep that in mind, especially when I do functional applied kinesiology testing with my patients, and if I find that their latissimus dorsi or their tricep muscle on either side is not fully locking in, I take that as an indication they may have a pancreatic problem. Those are the two pancreas muscles.
Wow. Interesting.
So then I'll really, you know, check the elastase, and, you know, sometimes I'll, you know, find all kinds of levels, but these undetermined significance levels, I think, are really worth considering.
And I have a question. I'm not sure if you'll have sort of a known mechanism behind this, but I certainly have had a couple of clients over the years whereby their pancreatic elastase has been over 500, but they've actually also had sort of visible undigested food in the stool. So is there anything that comes to mind that would explain why someone can be producing sort of seemingly adequate amounts, but still having that level of maldigestion?
Yeah, and I'm glad you brought that one up. You may see that also with undigested fat on the test, as you know. So you think, wow, they have great pancreatic enzyme levels, but why are they malabsorbing fat? Or why do they have undigested food in their stool? And so one thing to consider there is pancreatic insufficiency is not the only cause of malabsorption. A big one, if your patient also has bacterial overgrowth, is, especially with fat malabsorption, is the lack of saponification, emulsification of the fat. Pancreatic enzymes cannot work on large droplets of fat. It has to be turned into a micelle, and that requires bile. You know, you need that soap to mix the water and the fat. And if you've got these large droplets of fat, the pancreatic enzymes can only get to the outer side. If it gets micelled into tiny little droplets, then you can get a lot of surface area for the pancreatic enzymes to work on the fat,
right,
and the other nutrients, but not if it's still a very large droplet. So we know that overgrown bacteria, one of the things bacteria do is they turn primary bile acids into secondary bile acids, and secondary bile acids are much less effective at digesting fat than primary. And that is a mechanism by which bacterial overgrowth, together with or without, even without pancreatic insufficiency, can give you the same kind of malabsorption appearance.
Okay, interesting. And what are some of the, I guess maybe to complete this concept, what are some of the most common things that would contribute to pancreatic dysfunction in the first place?
All right. So one is, if you look a little north of there, lack of adequate stomach acid. If the gastric pH is too high, too alkaline, it doesn't trigger cholecystokinin and especially secretin as that gastric juice enters the small intestine. It should, the acid and to some degree the fat in it should trigger secretin. And secretin is what turns on pancreatic flow. So it can be secondary to hypochlorhydria, which can be tertiary, I guess, to taking acid suppressive medications, which a lot of the patients do. And it could be naturally occurring with age or other autoimmune and chronic conditions as well. So that is, I actually forget what the point of this was.
common contributors to sort of pancreatic insufficiency.
Yes. So I think that's a big one. Mm-hmm. That's a big one, is hypochlorhydria from any cause. Another would be diabetes. We know diabetes commonly is associated with delayed gastric emptying and gastroparesis. If you have delayed gastric emptying, even if you do make enough stomach acid, you're not gonna, you're gonna have a long wait between pancreatic activity in the small bowel and the food actually getting in there. That could be a factor too. Another would be just patients with chronic degenerative diseases and on polypharmacy. They are much more likely to have basic functional conditions such as hypochlorhydria or pancreatic insufficiency. Just, general lack of vitality and systems starting to break down and not be as efficient as they should. Certainly cystic fibrosis is the classic one, where plugs of thick mucus block the flow of the pancreatic acini, and alcoholism, as we know, especially when it leads to chronic pancreatitis, and chronic pancreatitis of any cause, can eventually destroy enough acini that you just don't have a whole lot of tissue left to produce these enzymes.
Brilliant. I really like that concept around those with sort of chronic degenerative conditions being so frequently experiencing sort of hypochlorhydria or low stomach acids. And are there sort of actual mechanisms that we know of that explain this? Because it does seem that, the majority of my clientele are moving towards or in that kind of state of hypochlorhydria, but they might not be on PPIs, stress levels might not be particularly significant. It's almost, from what you said there, it felt almost a little Eastern medicine like, this idea that there's a lack of vitality and these fundamental mechanisms just aren't working efficiently. But are there some more conventional theories there?
Conventional theories or research that shows that chronic degenerative diseases lead to
just that? Yeah, I guess that, why so many of these individuals seem to struggle with hypochlorhydria without maybe the classic PPI reason.
Yeah, well, let's consider this first. Robbins pathology, the sort of Bible of pathology at least in the US, one of the main ones, been around forever. I think it's in its 24th edition,
wow.
Something like that. I was always marveled when I would because I read that book over and over because I taught all of pathology for 17, most of it for 17 years. When I would read in there that it says that greater than 50% of people over age 60, 65 have chronic atrophic gastritis. Over 50%. So if half the population as they age has chronic atrophic gastritis, and as your listeners probably know, as the atrophic gastritis thins or attenuates the lining of the mucosal lining of the stomach, you lose more and more parietal cells. That's part of what you're losing. And of course, that's where you make acid, and that's where your stomach makes intrinsic factor. So B12 deficiency becomes more common as you get older, and hypochlorhydria becomes more common as you get older, and therefore you're going to have malabsorption to some degree of protein. You're going to have malabsorption of some of your major minerals and some of your micro minerals, trace minerals. You're going to have problems with lack of triggering of secretin and the pancreatic part of digestion. And if your pH is greater than 3.8, you're going to have both gastric bacterial overgrowth, which most people don't think about too much, except for H. pylori, but it belongs there, and small intestine bacterial overgrowth. And then you're going to have all those toxic metabolites, the LPS, the peptidoglycans, coming off those overgrown bacteria, going to the liver, leading to non-alcoholic steatohepatitis, burdening the entire system. So now you've got your major blood filter that's clogged, so to speak, if you want to use a common word. So it's a vicious circle.
Okay. So is it potential that some of that same, I guess, cellular loss that you were saying there is just happening in people with chronic illness almost?
Yeah, and you said it sounded more like Chinese medicine. Well, Chinese medicine and naturopathic medicine are vitalistic traditions, right? So they're going to sound a lot, I hope they sound a lot alike. You know, vitalistic traditions, the idea that it's not just a bunch of parts.
Yeah.
The whole is greater than the sum of the parts, and that there's a life force, chi or the vis or prana or whatever the system calls it, that guides and organizes the whole system. Yeah, so to me, if it's true that the major textbook of pathology says over half of aging people have hypochlorhydria due to chronic atrophic gastritis, and then B12 deficiency following that, probably folic acid deficiency following that as well, because acid is needed to properly digest folic acid as well as B12. That's a pretty major kink in the cog that controls so much cellular activity and cellular repair.
No, that deeply resonates, actually. That makes a lot of sense. So we've spoken about sort of stomach acidity, we've spoken about pancreatic enzyme production and bile and how they're all natural protective mechanisms against SIBO. And then I guess at the other end of the small intestine, we have the idiocecal valve. So would you be happy just to, I guess, share a little bit about what it is and how it can get involved with SIBO? Yeah.
So I have a whole chapter on that in that same book.
Excellent.
If people want more detail, but yeah, so I think of those three fluids at the top as sort of the upper gate or protector of the small intestine, and then the ileocecal valve at the bottom. And ceco-ileal reflux from the cecum into the ileum is an issue when the valve is less than fully functional. Now, in applied kinesiology, we talk about closed valves and closed ileocecal valve and open ileocecal valve, basically meaning sometimes the valve is hypertonic and doesn't open quite as well as it should. And sometimes it's hypotonic and doesn't close as well as it should. There's not a whole lot of research on this in SIBO. There's 1 or 2 studies that use the smart pill to check pressure, sort of manometric type of measurement at the ileocecal valve. And there's still debate about how important that is. What we seem to know about this from research is that as long as there's a good functional migrating motor complex moving things through every 90 minutes during fasting, it may not even matter if the ileocecal valve has been resected due to Crohn's disease or some other condition. You still may not be prone to bacterial overgrowth. At least that's what some research shows. So, we talked about the top and the bottom gates, but then there's that whole flow of the river, right, from beginning to end, which is the migrating motor complex, actually starts in the stomach, in the antrum. And I wrote a song about that because I write songs about things. I wrote a song about the MMC. But anyway, always comes into my mind when I'm talking about this.
Is that in the book too, or?
No, none of the songs. I still have to record those. I just do them live. Anyway, there is a YouTube site that has some old songs I wrote. They're not as much about gastroenterology. They're about pathology.
Amazing.
You can find those and listen to them for free. Anyway, that migrating motor complex is so important, and so it may be able to make up for an incompetent valve, a valve that is hypotonic and allows ceco-ileal reflux from that very high density of bacteria in the large bowel, millions per gram, into what should be a low density area in the small bowel. And often you look at measurements in charts and things about how much bacteria there is in the terminal ileum, in the lower ileum. And it'll start to approach what's in the colon. And I think that's because of this ceco-ileal reflux. But the better your migrating motor complex is, and if you're, say a person is doing things like modified fasting, going 12 hours or more overnight, they're really giving their migrating motor complex a good long period of time to clear out the bacteria from the small intestine. And that's probably really important too. That's, I think, why Dr. Pimentel really emphasizes meal spacing as part of his prevention program, dietary prevention program after SIBO treatment.
Interesting. Yeah, I find that with that, some respond really well to focusing on that sort of fasting and not snacking in between meals. And I can only assume that those are people that do potentially have a real issue from an MMC perspective. I imagine it could be used obviously during treatment ultimately as well though. So at the beginning of the process of eradicating the overgrowth, kicking in that MMC as best we can is going to be helpful.
Yeah, now, Pimentel's a researcher primarily. He doesn't even see patients anymore as far as I know. He's a brilliant researcher and prolific. And so from his point of view, he wants to see if his antibiotics worked. So he tells his patients, I think he still does, don't change your diet until after your test is normal. He wants to see, does rifaximin and neomycin work, you know, because he's starting to use herbal treatments because he's been around a lot of NDs that talk about this, but mostly focused on that. So he really wants to see if that works. He doesn't want them to start mucking around with diet until afterwards as a preventive mechanism. But yes, we certainly start the diet in some form, at least getting people experimenting and getting used to it so they can do it well by the time they're finished with treatment.
Yeah.
We start it early.
Excellent. And are there, I guess, just to maybe finish off the concept from an ileocecal valve perspective, even though it sounds like it's probably the least common of the considerations, are there any signs and symptoms that would get us starting to think about it within our kind of clinical decision-making process?
The symptoms are there's almost too many.
Okay.
It would be almost confusing if you weren't seeing a list of them written down. But some of the common ones would be right lower quadrant pain, right upper quadrant pain. I've seen right shoulder pain, tinnitus. Do you say tinnitus in UK?
Yeah, what do we say? I think I say tinnitus, but I just listen to so many Americans.
Okay, yeah, that's how we say. And sort of sometimes there's what we call a sort of a viral syndrome. People who always feel like they're sort of getting the flu, people with chronic fatigue syndrome, so to speak. They always feel kind of toxic and achy, like they're getting the flu, but they're just that way all the time. And I think of that as associated with the open ileocecal valve, just because of the bacterial contamination of the small bowel and the way that may trigger certain cytokines. And then some people just have general indigestion. But yeah, that right-sided abdominal pain or fullness or discomfort is a big one. And of course, there might be constipation or diarrhea if the valve is open or closed, predominantly. I certainly have seen people who have a mix of closed and open when I do functional testing, and I think there that it's kind of an irritable ileocecal valve. You know, it could go either way. But in terms of signs, I would highly encourage anyone listening who's a health practitioner, when you're seeing a new patient, you get the records from a previous colonoscopy and you read them. The patient may tell you, oh, it was normal. That means nothing to me. All the good, juicy details are in the report and perhaps in the biopsy report as well. But I have often seen, it's not every day, but I've often seen in the notes, it will say the ileocecal valve was open. Do you need more than that? No, you don't. That's it. Or I've seen other reports where it says clear bilious fluid was seen leaking from the ileocecal valve.
Wow.
All right, that means it's hypotonic to me. I've also had a number of patients who I look at their colonoscopy, and if they were trying to do a full colonoscopy and go through the ileocecal valve into the terminal ileum, they'll say, we weren't able to intubate the ileocecal valve. And that, to me, is a closed ileocecal valve. It was so tight, they couldn't get in. So then they have to follow it up with small bowel follow through or some other imaging technique from above so that they could see the small intestine in some way, or MR enterography, something like that. So these are clues, or sometimes direct quotes, that let you know that it's open or closed.
Brilliant. Okay. And then what are some of the sort of interventions that can be considered? I know there's a therapy called Clear Passage that I think is a potential option from I guess a manual therapy stance.
Well, there are many different manual therapies just to try to improve the tone, normalize the tone of the valve. And I teach one in my GI lab class, use it all the time. But Clear Passage is actually a physical therapy technique that specializes in recurrent small bowel obstruction and adhesions in the bowel and in the pelvis, as well as do a lot of work with women with endometriosis and people post-surgical conditions.
Okay.
But focused more on the ileocecal valve itself, there are lots of simple techniques. And also there are nutritional and botanical techniques. First of all, again, all the details are written down if anyone wants to see all this. But for instance, calcium is probably one of the most important minerals. So many people these days take magnesium, but you find a lot of people don't take calcium. Mm. And they're on a dairy-free diet because they find that they do better without dairy. That can be a problem. And lack of calcium, of course, is going to affect any muscle, and it can affect the ileocecal valve. So sometimes we're using calcium supplementation in different forms. Another thing is you got to realize that the adrenal glands are often, dysfunction of the adrenal glands are often behind problems with the ileocecal valve. Okay. Just as pancreatic insufficiency can be behind SIBO. So if it's a perfect, I always tell my students, if it's a perfect world where everything fits and makes sense, the clearest connection would be hypoadrenia and an open ileocecal valve. Sort of the low cortisol state, low DHEA state, low pregnenolone state, also leading to an open ileocecal valve or a hypotonic ileocecal valve, as opposed to a closed ileocecal valve being associated with hyperadrenia, people with very high levels of cortisol, sometimes together with low levels of DHEA, can tend to cause more, hypertension and Cushingoid type symptoms and more tone in the ileocecal valve, leading to often pretty severe constipation because that valve's not opening very often. So in a perfect world, that's the clear distinction. But you will find lots of different types of adrenal problems associated with ileocecal valve problems.
Interesting. And yeah, I know that's fascinating because we always talk about chronic stress having various impacts on the digestive system that could contribute to things like constipation, but I haven't really thought about it specifically from an ileocecal perspective. But yeah, that's really interesting.
Yeah, I mean, think about it. All the sphincters are parasympathetically dominantly controlled. So if your patient is in a sympathetically dominant state, they're going to have some issues with their sphincters. Mm. And if they take opiate narcotic every day for their chronic pain of some sort or other, they're going to have big problems with hypertonic sphincters.
Yeah, that's fascinating because I, for a good few years, have sort of used HRV monitoring with some of my clients. And I was finding a lot of them were scoring quite low, suggesting almost a sort of sympathetic withdrawal, so in a hypo type of state. And I hadn't thought about it from sort of a sphincter or valve perspective. So that's got me thinking about a lot of clients.
Well, have you noticed that your patients that are on beta blockers have a lot of trouble getting good HRV?
Let's have a think. To be honest, I struggle to think of a client that does have good HRV. Like, it really is. And I'm not sort of even exaggerating there. So yeah, that would be a challenge.
Yeah. Yeah, it's pretty tough to have good heart rate variability when you're on a beta blocker. I'd say it's near impossible.
Okay.
So there are lots of medications involved here too, you know?
Yeah.
Like I said, polypharmacy. Remember, I always like to point out that, yeah, there's studies on aftermarket studies on all these drugs. They're highly studied for short periods of time usually, which isn't always long enough because people take them for years and decades. But also, it's just as true that nobody really takes two different common drugs and studies them together. Or 3 or 4 that your patient happens to be on, or 7, which is common after age 60. That's an N of 1 experiment. And you're as a practitioner, you're gonna have to really, really work hard to weed out what is each drug's effect, what are the interactive effects, what's actually your patient's state without those drugs, because they've been on them for so long. You have a lot of teasing out to do to figure out what's going on.
It certainly adds another dimension to clinical practice.
Yeah.
Brilliant. Okay, so I think that is most of like what I will define as conventional protective mechanisms of SIBO: stomach acidity, pancreatic function, bile, motility, ileocecal valve. I'm quite interested if you have any thoughts on sort of the immune system, because I certainly see a lot of people with mycotoxins, for example, whereby they seem to have chronic SIBO. And my thought process is that although there are probably a few mechanisms going on, one of them is that their immune system is just compromised, and we know that's important in regards to regulating a healthy microbiome. Do you have any thoughts on that element of things, just from an immune SIBO perspective, I guess?
Well, I think of it this way. There are many studies that show that patients with celiac disease, which is quite a common condition, have a much more severe form of bacterial overgrowth. And in fact, that's the first thing that we tend to think of when someone diagnosed with celiac is doing a very strict gluten-free diet and is still having a lot of the same problems. Is you got to treat their bacterial overgrowth. And a third part of that triangle is Iga deficiency. So we know that Iga deficiency is also quite common in celiac disease. And that's why if you do a full serum marker panel for celiac, you really should do total IgA, as well as the TTG and the deamidated gliadin peptide IgA and IgG. You typically will do a total IgA, and a lot of these patients are IgA deficient. So, gosh, if secretory IgA in the gut and other mucosal surfaces and skin is the sort of surface immunoglobulin designed to cull out things that don't belong there before they get absorbed into the blood, especially through a hyperpermeable gut, that's your first line of defense to control the bacterial growth, to keep bacteria in check. And so, I mean, I think IgA deficiency is a classic example of how, if the immune system is subpar, you're going to be prone to bacterial overgrowth.
Interesting. Okay. And am I right in saying that sort of SIGA within stool is not really giving us a representation of SIGA from a small intestine perspective?
I don't know that it's even giving us a good idea of what's in the colon. I mean, think about it. Secretory IgA is secreted by mucosal cells. Some of it gets into the stool and passes out, but the stool isn't necessarily a great specimen for that.
Sure.
A biopsy would be better. We don't do that as often. We know that in irritable bowel syndrome, you know, back in the 70s when I was in school, before Rome 3, they talked about how functional disorders in the GI tract they were separated from organic disorders because they had no signs. There was no lab test. There was no biopsy that would show anything. It was just about function. It wasn't pathology, real pathology, you know, so to speak. And the problem was they didn't know what tests to do. They were doing the wrong tests. So now we know in IBS, especially post-infectious IBS, there are autoimmune markers, right? There's anti-CDTB and antivinculin that you can measure, and they'll be elevated in post-infectious IBS, attacking the interstitial cells of Cajal and slowing down the migrating motor complex, leading to bacterial overgrowth and chronic diarrhea. So we know now you can measure that. There is a test. We know that if you biopsy rectal mucosa in IBS, there are increased lymphocytes. There's increased intraepithelial lymphocytes, just like you see with celiac disease if you biopsy the duodenum. So, you know, we used to think disorders like this were less organic, less damaging. There was less in the tissues that you could find. They're just doing the wrong tests. And I think we'll find that with most of the functional GI disorders over time. You just have to know where to look. I don't know if I went around a corner there with the original question.
No, not at all. No, I think that was a good response and a great clinical pearls. So yeah, thank you very much. Is there anything else that you would like to sort of conclude with, Dr. Sandberg-Lewis? Anything that we haven't touched on in the world of SIBO that you think is important for us just to touch on?
Well, I think that it's just good to have the perspective that there are local effects from bacterial overgrowth, such as the gases, hydrogen sulfide, methane, all have their effects on motility, all have their effects on stool consistency and frequency. They all take up space, so they cause distension, so they can cause pain, and they can cause bloating, which is a major symptom. And I think one thing I'd like to put in a word for bloating. I've written several songs about bloating because, you know, until about maybe 12 years ago, when my patients would come in with bloating as a chief concern, I would think, get a life. Like, what's your issue? It's just bloating. And then at some point I got a little food poisoning, some bug, and I got very bloated. For about 2 weeks, I felt like I was 80 years old. You know, my wife and I take walks together, and I can keep up with her. And I was just asking her to slow down. I mean, my whole functioning was like an 80-year-old man who was not in good shape. And I shouldn't put down 80-year-olds. I'm sure a lot of them are doing fine. But it affects everything. It affects your mood, it affects your energy, your stamina, everything. And So these people coming in with saying it feels like there's a basketball in their abdomen, but as the day goes on, it gets bigger and bigger. All these local effects of the gas causing distension, triggering the nerve endings in the gut, causing pain, and really affecting so many different reflexes. You got those local effects from gas. And then you have systemic effects, because almost without distinction, it's clear that if your patient has severe enough bacterial overgrowth, they're going to have hyperpermeability. And I like to point out too that hyperpermeability occurs everywhere in the gut. You know, most docs think about it in the large intestine. Some think about it in the small intestine. It happens in the stomach, and proton pump inhibitors have been shown to increase the permeability of the gastric mucosa themselves. And it happens in the esophagus too. In fact, according to some research, almost 100% of people with heartburn, whether it's caused by reflux or other causes, have what's called DIS, or dilated intercellular spaces. If you do an electron micrograph of a biopsy of their esophagus, you will see leaky esophagus. You'll see those squamous epithelia are spaced further than normal. And so hyperpermeability, when that occurs, together with all these endotoxins, exotoxins from the overgrown bacteria, that's going systemic. And that's how you, at least one way, that you get all these systemic symptoms as well. And that's why, you know, depression and anxiety is also a factor, besides just the fact of chronic pain leading to adrenal disorders and issues with mood. It's profound what happens, and all starts in the small intestine, and it's all about a proper balance of the microflora.
No, that is an important point. And I guess just looking at the research coming out on all the different gut something axis, the gut bone axis, the gut brain axis, the gut liver axis, you know, the list kind of goes on, showing us the interconnection there.
Yeah. If you ever want to talk about the sterol biome, that's pretty amazing too.
Yeah.
That's the bacteria in the small and large bowel, especially small bowel, metabolize bile to create steroid hormones and control the whole blood sugar, insulin resistance mechanism.
Amazing. I think that might have to be round 2, Dr. Sandberg-Lewis. I'll have to get you back on. But no, that is fascinating. I spoke to Stephen Grant, who's a functional medicine practitioner in the UK, and we discussed a little bit around, I guess, blood sugar regulation and how some hormones that I believe are produced, at least in the gut and elsewhere. I think he spoke about GLP-1 as being one of them that is important within that whole kind of cascade of insulin production and blood sugar regulation.
Yes, and all the incretin hormones, which include that.
Okay.
And they are modulated by the intestinal flora.
Huh. That's
through
amazing.
the FXR, PXR, and G-coupled protein receptor mechanisms. It's fascinating stuff.
Brilliant. Well, if you are open to it, Dr. Sandberg-Lewis, I'd love to have you back on to speak specifically about that. I think it's an incredibly important topic, I guess, when we think about the cardiometabolic diseases that are just an epidemic.
Yeah, we could have a discussion on the relationships among the cardiovascular, renal, and GI tracts. That could be our next talk.
Perfect. I look forward to it. All right, Dr. Sandberg-Lewis, thank you very much for sparing some time to come and speak with me. It's a real pleasure and honor to be able to pick your brain for this amount of time.
You're welcome. I had a good time.
Good. Thank you very much.